Hello, everyone. My name is Rich Zink, and I'm the Managing Director of REMEDI Operations at the Regan Street Center for Healthcare Engineering at Purdue University. Thank you for attending this session to learn more about our collaborative approach to improving patient safety. Our agenda today will give you just a quick overview of our center, the Regan Street Center for Healthcare Engineering, provide quite a bit of information about the project itself, uh, give you an overview of infusion pumps just so you understand the data and what they do, so that when we get to the demonstration it will make a bit more sense. And then we'll finish up with just a couple of slides on what we think the vision holds for REMEDI. And so as I said, I work at the Regan Street Center for Healthcare Engineering. It's a mouthful, so we just use the acronym and pronounce it ARCHIE. And the Regan Street Center for Healthcare Engineering is an interdisciplinary research center, applying engineering and business principles to transform healthcare delivery. So we work with all the different colleges, schools, and departments on campus, whether that be the industrial engineers, the business school, the biomedical engineers, computer science, statistics, nursing, pharmacy. We don't have a med school, but anybody that wants to help improve healthcare delivery, we work with. The REMEDI project is an acronym for the Regan Street National Center for Medical Device Informatics, REMEDI. Two key parts of REMEDI are the community. So this is a group of people that are sharing knowledge and capturing the best practices, and they're also sharing data. And they can use our tools to look at their data in unique and different ways, and they can also benchmark other hospitals. So the devices we currently focus on are really in the medication use process, so when patients are getting medications, so that makes our current focus infusion pumps. So who are we in this collaborative? So I'll start in the top right-hand corner. So we have the vendors. So the vendors listed there, their logos anyway, they're the primary infusion pump vendors. Our thought is if we're going to make a difference and really transform healthcare delivery, we need to have everybody at the table, including the vendors. And the bottom right is the university. So we have our development team, we have faculty, students, staff, all working to leverage the data and apply research to improve healthcare delivery. Bottom left are the Friends of REMEDI. So these are organizations across the nation that are involved in patient safety and healthcare that have either presented at I think they've all presented at our conferences actually, and support the efforts we have. And then not least, in the upper left is the community members. So these are the heart and soul of our collaborative. So these are the clinicians that are providing the care at the bedside, primarily pharmacists and nurses, at least when we're talking about those that are working with infusion pumps. So the data, we get data from hospitals across the U.S. and 4 other countries. So somewhere around 414 facilities represented by the hospitals/systems that are joined the REMEDI Collaborative. You can see we have a lot of data that they've provided. And that, again, it's mostly infusion pump data, but we have a little bit of data on ventilators and physiological monitors that I'll show you. Again, the benefit here is for the hospitals to have an opportunity to look at their data in new and different ways, and even more importantly, to benchmark other hospitals and how they use the data. So one of the things we'll talk about as we move along is these devices tend to be very noisy. If you've ever been hospitalized or visited somebody, you're probably tired of hearing the beeps as much as the nurses hear them. So that causes something we call alert fatigue, and the dangers of that is the nurse becomes desensitized and either misses the key alarms or just takes them longer to get there. So alarm fatigue is an important issue and one that we try to help address among other patient safety issues. So the background on infusion pumps. And so they are a medical device regulated by the FDA. primarily deliver fluids, medications, and other nutrients, typically intravenously. There are a lot of them around the world, giving a lot of infusions. And if you're a patient in a hospital, 90% of those are hooked up to receive an infusion. So in particular, we're going to talk about smart infusion pumps. So a smart pump is a pump that delivers these fluids, but it has a brain. So it contains a library of medications. So, hey, I need to give somebody a painkiller, or I need to give somebody an antibiotic. So the clinician chooses the appropriate drug. And then there are different guidelines for different areas of the hospital on how to give that drug. So if I'm recovering in the ICU, I might be allowed a little bit more medication than if I'm just a patient in for some sort of day procedure. So those differences can be in dosing, concentrations of those drugs, et cetera. So these smart pump features collectively are known as the dose error reduction software, the dose error reduction system, and we often pronounce that DERS. And again, DERS is really just a safety feature for the clinician to try to avoid over and underdosing of medications. So we know there are a lot of pumps out there, and we know they're error prone. So some data from a few years back shows there are a lot of incidents. An adverse event is something that's undesirable. Something bad happened in some either harm or near harm to a patient. So we don't want those. So that led to some national efforts to try to improve the safety of infusion pumps. And I'll talk about that here in just a little bit. The problem still exists today. So this is just a snippet of a newsletter from an organization called the Institute for Safe Medication Practices that came out this summer. And they're saying you still have to look at your infusion pump metrics to improve the safety. So we still know there are problems with these infusion pumps, or there's still errors occurring, and we know there are a lot of them, so we're going to look at the data. So what types of data do the clinicians look at? Again, they'll look at these drug libraries that are in the smart pump. Again, these are the drug names and the details about how you can administer them. The alert data is what happens when the nurse is programming and exceeds one of those limits. So, hey, I'm going to give Rich this particular medication. I program it in there, and it says, hey, that's too much. You'll need to reprogram to a lower amount. So those are alerts that occur during the programming stage. Compliance just means, hey, are you using those smart pump features? There are reasons occasionally to not use the smart pump features. For example, it's a brand new drug that hasn't made it to the library, or maybe it's an emergency situation and you just need to pump that drug in there. So the compliance rate is how well are you using the smart pump features over not. Again, I think we'd prefer that everyone uses the smart pump features for the safety of their patients. And then the pumps also alarm through normal use. Different kinds of alarms listed, air and line occlusions, low battery, and there are a bunch of other metrics we could look at, but these are the ones we'll take a look at live in the demo. So quick introduction, this is Archie. He is our mascot for the project. We chose a Roadrunner as a mascot because both alarms and Roadrunners go beep beep. And he does have a headshot that he uses for different research papers and other articles that he writes. He does consider himself a programmer, so you can see him with his developer glasses on as well. Since I know you're going to want to use Archie in your activities, I'm going to teach you how to draw him. So it's very simple. Just draw some circles and then draw the rest. So many of you have seen this type of this meme before, and I bring it up only because I think it's very analogous to what we're asking the clinicians to do today. We tell them use the data to improve patient safety, but we don't provide any of the details in between those two steps. And that's where REMEDI comes in. We're there to try to help them interpret the data to improve patient safety. So when did we get started? So we get started back in that same time frame that there was an uproar across the nation about the issues with infusion pumps back in 2009. So we were also approached at that time by the Indianapolis Coalition for Patient Safety and asked if we could help. We said, sure, we can build you something. So we built them something. And it had to do with those alerts that occur at the pump. BD and ICU Medical are two different pump vendors. The majority of the community had BD branded pumps. So we created that tool for them first and expanded to ICU Medical. After we were up and running for a few years, the community came to us and said, hey, we'd like a tool that helps us look at the compliance. Again, how well are we using our smart pump features? So we added that for those two vendors. As a new hospital joined in 2015 that had yet a third vendor's pump, we added them. So one of the things you're going to note when we see the demo is we are vendor neutral. So we'll have data from multiple vendors within the system, and that we don't care. We're going to show it all to you. We added a drug library tool to help the hospitals compare limits and concentrations and other administration criteria among themselves. Before we had it in the database, we shared documents, and so they'd have to go in and open one of the hospital's drug libraries in Word format, open the search function, type in the drug name, and search, lather, rinse, repeat for any other document. So adding this feature really helped them out, made it easier to look at it. We added a fourth vendor for at least the drug library side in Smith's Medical in 2017. And we introduced another application really focused on looking at the alert data, but it was based on some of the research done by one of the industrial engineering professors. So here's where we're learning from the data and feeding it back, what we've learned, to the community. We expanded to different medical devices, including physiological monitors and ventilators, mechanical ventilators, in 2017. And this year, the hope is still to get out a new alarm module for the infusion pumps. Clock is running, so we'll hope that we get that done. I think we're still on target to do that. Along the way up at the top, you can see that we've grown in the number of facilities to the 414 reported before. So we are an active and engaged community. We run our application on top of the HUBzero platform. We call it our research and collaboration portal. It is HIPAA aligned, catalyzecare.org. Even though we're not getting any HIPAA data or protected health information from the hospitals, it's just device data, we treat the data as if it is, and so we are HIPAA aligned, and the HUBzero team provides that service for us. They are also our development partner in developing the tools and applications that run on top of HUBzero. You can see some of the details on the front end and back end and in our data stores, and how we work to incorporate that in there. So that's that. So I'm going to jump over and actually show you the tool in a live demo. What I'd like to go through is how members join our collaborative, show you some of the collaboration tools that are available off our member dashboard, show you how we get the data, or the hospitals provide us with the data, and then go through some of these applications, the infusion pumps as well as the monitors and vents. So let's jump over to my browser. So I'm going to run in a development database only because I'm protecting the identity of the hospitals, but much of the data is the same between the two systems. So I am going to go, so users come to Remedy Central, and the first thing I wanted to show is how they can join. And there's a button to register to become a member. So if you want to join, or a hospital wants to join, they pick which medical device they're interested in sharing data around, enter their contact information, their organization name, and then they can either electronically sign off or get a copy of the membership agreement that they can have signed or redlined at their own site. So that's we built that as a custom extension to the HUBzero platform so that we could make this easier for people to join. So that's the key on joining, and then I'm going to go ahead and log in. It remembers me logging in from before, so I'll just let it do that. And now this is our member dashboard. So this is what you see when you log in. I will clarify that as an administrator, I have every single thing turned on, and my dashboard looks a bit more complex than what most members see. But one of the key things we're trying to do with the member dashboard is to highlight the collaboration tools. So down here in the bottom right-hand corner, center to bottom right, is the latest discussion threads. So people can post questions and their peers can answer them in regards to issues they have. Some of this is old data in the development system. We have newer data points in the new one, but just wanted to provide this as an example. We also have some other things that show up under the community link, such as a contact list. So if you want to reach out and talk to somebody in the collaborative, we provide a primary contact. These are the discussion threads. We have a set for each of the different devices. And then we also keep the document repository. So one of the things that we do as a community is on the infusion pump side is we collaborate by having 3 virtual conferences a year and 1 in-person conference. So we store those documents and the WebEx recordings online so people can come and look at them. Now, how do we get their data? I'll say the technical term is SneakerNet. They go into their pump vendor's tools, and depending on the pump vendor, what the tool is, then they export 1 or more report for each type of data. So I'll just pick one and I'll say, hey, I'm running BD Alaris pumps, and I want to get the data for alerts. I'll go into what's called the Infusion Knowledge Portal. I'll run the all available columns data element report, save it off at CSV. Similarly, if I wanted the compliance data for BD, I'll run the Guardrail Suite MX usage by profiles report, save that off as CSV. So depending on the vendor, it's a different process to get the data out, and that's what they do. By the way, there's, again, no PHI, it's just pump data. So there's no HIPAA violations there. They'll default to their own hospital name when they come in here, and then they can drop off 1 or more files here and walk through the process to upload the data. So they go into they go into the vendor software, export it out, say to the desktop, log into to REMEDI, and drop it off. So that's how we get the data. So let me show you some of these applications. So I'll start just working down the list from the infusion pump side. We'll start with the drug libraries. So the first thing that comes up is a list of the hospitals as well as a list of the drugs. So we're interested in a particular drug, so we can find that drug in possibly 1 of 3 ways. If it happens to be in the suggested list, we can pick it right off the list. We could ask for the full list, and we can see the drug here, or we can just start typing in the field and let it auto-populate. So I don't know, what do we want to go with today? Maybe some propofol. So now I have propofol, and now on this side I say, okay, now I want to look at the drug. Which hospitals have that drug? And it looks like all these do. So I'm going to say I want to compare my settings to everybody's. So I'm my hospital, and I'm going to compare to 76 other hospitals. So the system is looking at 77 drug libraries. So we'll request that happen. And again, I'm on the system, so maybe it's slightly slower, but I'd say it's pretty close to the same speed as production system. So the first thing that comes up is a summary or overview tab that shows different things. So we can see that the collaborative is fairly consistent on what units they use. Most are administering propofol via milligrams. Most of them have a concentration of 10 milligrams per ml. That's good. We like to see that. And this is more of, I'll say, more of a bag size. So these all turn out to be the same concentration, but they're different bag size that are attached. This information here, depending on the way you administer the drug, shows the different ranges for what we call upper hard, upper soft, as well as lower soft and lower hard limit. So when you set a hard limit, it cannot be exceeded. If you reach one of those, then you have to reprogram to something lower, while for a soft limit, it says you can go ahead and do it, but it asks for I'll call it a double confirmation that you really mean to do it. This is the range of values for the upper hard, shown in box chart form, so from 0.5 to 200, with the middle 50% here. And then this is just a graphical sanity check. How do my limits compare to other hospital limits? And I can just kind of scroll down and I'd say, okay, most of us are the same. These guys seem to be way out here. So I might reach out to whoever the contract is at ARCHIE system and ask why they have facilities that are running these much larger soft limits than anybody else. So that's just a very high overview of what the different settings are. And then we can drill down and look at the specifics of the details. So for my hospital, I can use propofol in an adult profile. We're using the BD pumps, no specific therapy. Here's the concentration in units. And I have a soft min of 1, a soft max of 100, and a hard max of 200. I have other entries that are either different areas of the hospital or different requirements. And then I can look as well at other hospitals, and I can do it in a couple of ways. I can leave my hospital at the top and just scroll through all the other hospitals that have it, left and right, or I tend to flip over and look at them all at once so that I can make you guys really dizzy by scrolling the whole list. So now you can scroll and scroll and scroll and scroll and see all the different types, and you can see we have different vendors. So here's one that's ICU Medical, here's one that's Baxter. I can filter this data in several ways. I can say, hey, I only want to look at, let's say, the children type profiles. So if I clear these out and say, hey, I only want to look at the pediatric ICU and the neonatal ICU, as well as the neonates and the peds, now the only listings I'm having or showing are the ones for pediatric neonates and their equivalent critical care areas. So little people different in many different ways. They're just not small. We can also filter by vendor. So, hey, I only want to look at BD. I could filter out there, or I could look at specific concentration. So that's a general idea for the drug limit library tool. Pick your drug, find your comparison hospitals, and work your way through it. So now I'm going to jump on to the compliance. So I'm going to just go ahead and stick with my hospital. My hospital happens to be, what, an 8-hospital system. So if I say, show me the data for my hospital, it does. I'll just change the y-axis so we can see different. So if you want people to use the smart pump features all the time, you'd want a compliance rate of 100%. And as I mentioned earlier, there may be reasons why you don't reach it. So as a system, the dark pink magenta line shows what my compliance is for our entire system. It's about 83%. If I wanted to look at any of the hospitals in my system, I can hover over the legend and see how each hospital is doing. I can change the date range by looking at the last month, 3 months, 1 year, 2 year, 3 years. Just as simple as clicking on these quick clicks. So I get the updated data here. I can also change date ranges, either length or start and finish. To look at these, I can go, if I go back way far back, we just have some legacy data. Other ways to look at that same thing, but slightly different, is now I'm going to show my hospitals one at a time, and then I'm going to show how each care area within the hospital is doing compliance-wise. So it's like, okay, I can see it that way. I could flip it over and look at it the other way and say, okay, how are we doing in obstetrics? These guys are doing, 83%. These guys are less than 50%. So maybe within my own system, we could reach out to somebody at Skyview South to learn how they're have such a better compliance or higher compliance than my hospital. And then the last way to look at the compliance data is just to look at the raw data itself. So again, how do you get that percentage? You take the number of infusions that are compliant over the total. This calculates for each of those facilities, roll it up by hospital, you get it. And again, this is all real time, so the data changes slightly as we change the date range. And you can see spark charts that show what the current pattern is or trend for each of those hospitals. One of the beauties of the system is that you can compare yourself to others. So if I just start picking some hospitals randomly, semi-randomly, hopefully I'll get some. We'll see if we got multi-vendors, and we did. At least we got one that has Sigma, which is a Baxter pump. So for this time frame that's selected, looks like a 1 year. Of all the hospitals I selected as a group, they roll up to 91.4 compliance with who's got the best, these guys. My Lesser Valley running 98% compliance. Again, I can flip it back and look at it in more of a chart form. Just to show it a little easier, I'll show it with the dynamic y-axis. And again, we can go back as far as we want to look at it. This is actually some real data. If I highlight over the Valley Bloomington Clinic, you can see back on the far left side, they were running compliance somewhere around plus 80%. And then they made a huge jump from here to there. Again, Valley Bloomington Clinic. When I saw that happen, I gave them a call and I said, did it just happen or did you guys do something? And they said, we did something. And they explained what they did. And I said, well, that's a great story. You need to tell that to the collaborative. And so we scheduled them to give a presentation to the collaborative in one of our virtual conferences. So now we're learning from each other on how to improve compliance, which also would improve patient safety. So that's the compliance module. Again, looking at how well we're using the smart pumps. So now I'll jump into looking at alerts. I should pick my hospital probably. Again, we're a system of a number of hospitals. I think it was 8. So once I pick that, I can look at the summary of an overview trend. So over this 3-month period, looks like the number of alerts are going down. These are the top 10 alerting drugs for that time frame. So I identify those. I can slice and dice this data in other ways. All right, so where are the alerts coming from in the hospital? I'll look by profile. So most of them are coming from my adult units. In our hospital, we call them adult, okay? So 90% are coming from the adult units. how are these infusions given and where are they coming from? Most of them are from a primary intermittent duration as opposed to continuous dose. So a continuous dose would be an infusion that runs for something closer to an hour or longer, while an intermittent is something shorter than that but less or greater than, I don't know. So let's say it's somewhere between 5 and 30 minutes, just swagging in. But there are different ways you can give them. A bolus is push as much drug as you can, or a large amount of drug in a short amount of time frame. Slicing, dicing, yet a different way. What did the clinician do when that alert sounded? So they overrode 81% of the times, meaning I really mean it. I understand I'm near the upper or lower limit, but I really mean it. Let's do it. Hard and soft. So most of these alerts, I'm going to guess, are soft, just because we have the ability to override. You can't override a hard, so most of these are soft limits. And then I can see which hospital is getting the most alerts or generating the most alerts in my system. So Creekside Southeast is generating the most alerts. Now they may be the biggest hospital in the system, but it's one way we can slice and dice. If we wanted to drill down in any one of these, we could just switch and say, hey, I just want to see, what was that, my hospital, Creekside Southeast, was that it maybe? So if I just asked for one hospital, now I'm just going to see their data, and if I went back to the general trend, probably a different look. I don't think heparin was the #1 alerting drug when we looked at it last time. So there are different number of drugs that are here. So other ways we can look at it, we could slice and dice on the profiles, or just filter on the profiles and other fields as well. But let me just show you some of the other charts that are available. So we could look at time of day. So when do these alerts occur throughout the day? So a lot during the first shift, let's call it. As we go into the afternoon, start getting into the evening, fewer and fewer happen at night. A little bit of a heat chart. I tend to look at this heat chart and say if I see a lot of heat on the weekends or early hours, I'm wondering if it might be a training issue, under the assumption that maybe our least skilled, or at least those with the least amount of seniority, are working those shifts. So maybe a training intervention would help reduce the number of alerts. We can look at such things as clinician response. So how often do you override for each reprogram? We can also look at how quickly they override those alerts. So what do we see? So 55% of the time, once the nurse sees the alert, they respond in 2 seconds or less and override that alert. And then there's, I'll just show you one more way we could look at the data. We could take more of a deep dive look at the data and say, okay, what's really happening here? So we're going to introduce something called times limit. So for these almost 5,300 alerts, they're actually all plotted on this this small chart by taking advantage of this thing which I'll call times limit. So times limit is a formula that uses whatever the programmed value is divided by the limit value. So if the limit is 10 and I program 100, then I got a times limit of 10. So every time I program a whenever I have a times limit of 10, then I'll find 10 on the chart, and then how many times it happened, I'll plot the in moving upwards. So here's a point that the times limit was, what, almost 5,000. Thank goodness it only happened once. So we look at it and it's like, okay, so they gave this particular drug. It was 5,000 times, and it was a soft limit, and they really meant it, so they overrode that alert. So that's one way you can look at this type of data. You can start drilling down into each of these and see if it's an issue with potentially the design of your drug library that's generating the alerts, or maybe it's the practice at the pump that's different from the design of the library. So these are all tools that they use to look at those particular cases to understand what's going on with their alert data. So here's I mentioned that we have an alarm module that we'd like to put out this year. This is some existing mock-up data, and it's more mock. It's an actual development in the development system based on real data. So now we can see, hey, the top 5 contributors to the alarm come from patient-side occlusion, bolus, airline alarm, etc. So if I was going to go after any particular alarm type to try to reduce alarms, I would focus on this one. Are any particular drugs generating more alerts than others? Absolutely. Are maintenance fluids generating a lot of alerts? So again, a brand new feature application that we hope to release yet this year. Since you tend to be data analysts and working with big data sets, I was going to show you the limit locator, which was based on some of the work done by a researcher, an industrial engineer here at Purdue, who used to work in fighter cockpit design, and was trying to come up with a way to look at the data instead of looking at let's say the top alerting drugs. Go find those drugs or medications that potentially we could change the limits to get rid of some of the alerts. So what he did is he said, okay, what if I go look at all the combinations of drug profile, which means care area, the field limit, how you can give it, the therapy drug could be used for a couple of different indications, and then whether it's above or below. So if you go look at all these different combinations and look at what type of actions are taken by the clinician, either overrides or reprograms, you can plot that on a chart. So I'm going to pick one that might be easier to see. So let's take potassium chloride. I'll try another one. Let's do, it's a below limit, but it will still work. Oh, it's above limit. Okay, so for dexmedetomidine in critical care at continuous dose above maximum, there were 31 alerts in this 3-month period. Okay, those are plotted on this graph at whatever the program value was. So when the nurse programmed 9, that happened once. When they programmed 8, it happened once. And then you can go all the way through, and if you add these all up, you get the 31. Now, the dots are color-coded by what the nurse did. So the yellow ones are reprograms, and the purple ones are overrides. So what the algorithm said is, if this is my current limit, the red line is the current limit, which is 0.7 mics per kilogram per hour, can I move that to get rid of overrides and not lose any reprograms? And so you can see if you move this to the right, you'll get rid of overrides all the way until you get here. So the system did some work for us and said, okay, great. If you move your limit up from 0.7 to almost 2, you'll be able to get rid of 24 of those 31 alerts. Is that a safe thing to do for a patient? We don't know. We're not clinicians. But it's a bit of data that then can be used by the clinicians to make a decision on whether that's a safe move or not. And maybe they don't want to go to almost 2, but they're okay with going by 1.5 or 1.3 or whatever it is. They can scroll this along and try different things And even if you move past, it just says, hey, you're going to miss some detections of reprograms. So I call this one as a little bit more of trying to find the needle in the haystack, as opposed to what we've done up to this point, which is a lot of data mining and drilling down in the data and trying to find the interesting things. This one pops the interesting information to the top. All right, so let me just pick on one of these other two. Who do I want to pick on? Let's pick physio default. So these are physiological monitors that get selected. So physiological monitors you get hooked up to, they measure such things as your blood pressure, your heart rate, your respiration rate when you're a patient. So I'm going to go look at my hospital, and now I've got some different tools than I had to select before. Could pick hospitals that are like me or of a certain type. So, you know, I just want urban hospitals that are teaching hospitals with 500 beds, and I don't care if they're for profit or not. I could select those. Or I could geographically select by state. Or if I knew my hospitals, I could just go ahead and pick them from here. But for a demo, I just think we ought to pick them all. So we'll pick them all. So now I'm going to compare and look at the data for physiological monitor with all. And then how do I want to look at it? I can look at adult populations, pediatric populations, neonatal or mixed, in a high care level, so let's call it an ICU, step down or med surg. Let's stick with adult ICUs. And then which alarms do I wish to see? Oh, show them all to me, because they're here. It's thinking. It is a development database, but has limited resources. Oh, it did get, I just wasn't patient. It finally got there. So what it shows is that this is the alarm type. So this is a heart rate. It has what we call a high priority when it's set. And when it reaches 54, it's a threshold for alarm. And we can see that the distribution for the hospitals, all the hospitals in the system, is whatever that is, 11 maybe, to 107 in the box chart format. And then I can see the same thing for the other alarm types as we go. And then I can see what each hospital sets it at. This data doesn't change because it's the summary of everything you looked at. But you can see exactly what the distribution of these different alarms are. So, hey, I set my high heart rate at 54. There are some people that are setting it less than that. Does that mean it's safe for me to set mine lower? Don't know. But at least it gives some data to help the clinicians, again, make decisions to take care of their patients. The other part of this is what the priorities are. So I guess we have enough showing just with apnea. Maybe not. Let's just see what some of these other things look like. So these are all different settings in the particular physiological monitor as it's trying to detect different types of heart rhythms or different actions. And then what level does each hospital set these as far as priority? So I think of high priority as I'm the nurse. If I get a high priority alarm, I'm going to run to the bedside. If it's a medium level alarm, I'm going to walk quickly to the bedside. And if it's a low level alarm, I may just say, okay, that's informative. I'll get there when I get there. But you can see at my hospital, I've set my apnea threshold for medium. How does that compare to the entire population? Pretty even distribution across the hospitals. So I'm okay. There's some that said it differently. I'm all right with that. And if I have more than one unit in my hospital, I show it there. So I think in the interest of time, I'll stop the demo and just run back and finish up with just a couple of slides, and then open it up for questions for any of you that have questions. So where do we think we're going with REMEDI? So we've offered the service for free since 2010 and are currently moving to a fee-for-service model to try to at least cover some of our costs in providing the service. So we'll see that starting in 2019. We'll continue to focus on growth by adding additional hospitals in the U.S. and internationally. If we can help more patients, we want to do it. We'll continue to build new and better tools for the community so they can slice and dice their data, look at it in unique different ways than they can today. We'll continue to expand into other medical devices, and if I had to guess, I'd focus on other devices in what we'll call the medication use process, and I'll show you a couple examples of those in the next slide. And then we'll want to join the data together. So even today with the pumps and the monitors and vents, if I was a patient, wouldn't it be interesting to know what my total alarms was? So I got some that were generated because I was on the infusion pump, some came from my ventilator, and some came from my physiological monitor. When staffing a unit, I'd want to put nurses on. I wouldn't want to give one nurse the responsibility to work on the top patients that get the most alerts. I'd want to balance that out a little better. So knowing the total alert or alarm volume by joining the device data could be helpful. And then linking it to the patient data could also be helpful, and I'll describe that more in this next slide. So where are we today? Again, we've got the infusion pumps, the monitors, and the ventilator data. If we expand to other devices in the medication use process, so for example, these automatic dispensing cabinets kind of showed in the middle, ADCs. The nurse will go there to pull aspirin or ibuprofen tablets out of it to take to the bedside. There's a lot of data associated with that. Computerized provider order entry. When I order, I'm a physician, I order a new drug for a patient, I get warnings that, hey, there's a drug-drug interaction that you should take advantage of or be aware of. Does that change your decision to prescribe this drug or not? So lots of data associated with these devices that are used in providing medications to the patient. So again, we want to be able to connect those together. As I mentioned, getting the patient data. So the patient data in the electronic health record would include stuff like my vital signs, my medical history, my lab results, images if I did x-rays or other, my medication list, my diagnoses. So today I can say, hey, whatever you did to the pumps reduced the number of alerts or improved compliance or things like that. But what I can't say is, well, did that improve patient care? I don't know until we connect those data sets. So then I can say, hey, what I did on the device, I can measure the impact on the patient. And that the impact may be some of these traditional measures of health, the decreased length of stay, or fewer readmissions to higher level of care, fewer adverse drug events, that kind of thing. So that's what we want to do long term, if looking in the future. What really happens to the patient when we deal with the devices? So just a couple of final thoughts. We're all consumers of healthcare. We're all going to be on the other side of the infusion or the monitor in the future. So don't we want everybody to have as much information as they can to improve our care? Again, I'm a big believer, and if we're going to make a difference in any of these, areas that we all need to work together, whether it be the vendor, the clinicians, the researchers, anybody else that has a say or an opportunity to provide input. We should take advantage of that to see if we can improve it. And then I look to you people to continue to provide us the technology to do this. The data has to be private and secure, all stuff you know. How do we look through millions of alerts, millions, tens of millions of infusions, and come out with the most interesting information and the most valuable information to whoever is looking at it? Those are the kinds of things that we're going to look to you for to help us as we move forward. So with that, I'm going to open it up for questions and leave you with some contact information.